guys are in the ER, you may walk into a room and someone is literally in a coma, so you wouldn't say they're awake, alert, oriented times 3, would you? No, they're not. And so then if you're going to put a stupor or coma, you also will then further identify that. So you would say they're alert to verbal stimuli. You walk in, Kayla, Kayla, Kayla. She awakes, she's alert to verbal stimuli. I go in and say, Kayla, 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 and she's not. She may be unarousable to verbal stimuli. But if I give her a sternal rub, where you take your knuckles and you rub really hard on a sternum, that's how you induce pain in someone that's in a coma or stupor, to see if they're arousable to painful stimuli. And that's something you would document too, if they are or if they're not. So, you see we go from awake, alert, lethargic's in the middle, and then we go to stupor, okay? So lethargic is this wide array of things, from fatigue, malaise, appears tired. Some people will say don't ever use the word lethargic in a medical note because it's too broad of a term. But it is a term, you can use it, but if you do use it, I would identify it. I would further explain it. So I would say appears lethargic, comma, appears fatigued, but will answer questions and follow simple commands. Does that make sense? Mm-hmm. So if you're going to use lethargic, you have to then further give more information behind it. So I said you're going to say AAO times 3. So O times 3 is that they're oriented to person, place, and time. So if Meredith comes in my office and she's like, hey, I'm here today, my left toe hurts, I fell, I was running, I stubbed it, I can walk on it, I just want to know if it's broken. I'm going to assume, if we're having a conversation back and forth, that she's pretty much alert to time and place, right? But if Meredith comes in and I'm like, hey, what happened? I'm sorry, what'd you say? Okay, what's your name? Okay, where are you? I don't know, my mom just brought me here. I don't know where I'm at. Okay, what's today's date? So you go through those things and then you document. So she's awake, but she's not really alert. She's mumbling, difficult to understand what she's trying to communicate to me. She's not oriented, she doesn't know her name, she doesn't know where she's at, and she's unable to tell me today's date. So document those things, especially in the elderly. Anyone over the age of 65, this is how, remember I said Thanksgiving and Christmas, everybody wants to fix mama? So I use my documentation all through the year. So if I feel like they're starting to decline, I would start saying, tell me your name today, where are we at, and who's the president, or some type of current thing, what month is it, what day of the week is it, to see how oriented they are. And you will see what happens is they lose date and place first. Like, so they won't know who the president is, or they won't know that it's January, or they won't know today's Monday, or they won't know that it's 8 o'clock. Sometimes they'll say, I think it's the morning time, but they won't know the time. And then after that, they'll lose, where are you? They'll say, I'm at Amy's house. I came to your house today. Okay. And then eventually they'll lose their name. So that's the progression of orientation. So if you, especially in the ER, this is so important to document. People look like they're talking normal, and then you ask them who the president is, and they say a name you've never heard of before, or they speak another language like Klingon or something, and you have a high suspicion for some type of drug use or altered mental status. Okay. So in the journal appearance, you're going to document development. So this is just a brief, quick overview. I would say everyone in here is well developed. Everyone has developed appropriate musculature. Okay? No one is it has acromegaly, which we're going to talk about. No one is has a very underdeveloped stature. Have you ever seen a patient with cerebral palsy? You know how their muscle tone is very flaccid, they're very thin, they have atrophic muscles. They would be underdeveloped. Their musculature hasn't thoroughly developed. Okay? And nutritional status. So we say well-developed, well-nourished is how we would describe most normal people. You also have to say if they're undernourished or overnourished. So undernourished, we have 3 words to describe that. They're thin, they're frail, and cachectic. That's a progression. Thin is up here, frail is worse than thin, thinner than thin, and then thinner than frail is cachectic. And that's where you have muscle loss, okay, muscle decay. Overnourished, we're looking at BMIs over 30, so then you have overweight, and above overweight you have obese, and then top of the line we have morbidly obese. And you're gonna learn what these numbers, what BMI classifies you in which things, not in this lecture. And you will be able to, document that in their chart. Also document hygiene. Are they well put together today? I mean, they don't have to match, or they don't have to be wearing name brand clothes, but are they wearing 17 shirts and no pants? I mean, like, you have to be able to put the whole picture together. Are their clothes appropriate for the season? Or did they come in a tank top and shorts today? Right? You may think there's something going on with them metabolically. Or if it's in the middle of summer and it's really hot outside and they've got on sweaters and layers and clothes and they're not sweating. Right? There could be something wrong. You have to document that. Always look at their hair and their nails, just their general appearance. You don't want to, I mean, if there's a lot of dirt under the nails, I mean, if they're a mechanic or a carpenter, they do that, you have to understand that. But if they're not, I mean, this could be a sign of poor hygiene. Also, people that have poor hygiene, they may have an issue with compliance with medications you have to think about, and they may not be on top of their preventative care. And so, you're gonna walk a red line like, oh, I don't wanna say someone looks dirty in my note, and then they read that, and then they'll give me a bad review or bad survey because I said they appeared dirty. But you can say they're appropriately groomed or inappropriately groomed, not dressed for the correct season. They appear unkept. Malodorous is a term. If they smell not good. If they appear disheveled, if like half of their hair is in a ponytail, half stuck to the side of their face. I mean, you know, they just don't seem put together, as they have a disheveled appearance. You also want to document their speech and general appearance. Are they slurring their speech? Are they using their words appropriately? If they're using their words appropriately, I don't document it. If I can't understand them, or I feel like they have a hoarse voice, or they're very slow speech, and I see this in my mental retardation patients, that they just takes them more time to form their words. They're very slow speech, and I will put that. Has a very slow speech. For some people, they come in and they're just so excited and they've got all this stuff going on and they've just got to get fixed. I say they have a fast-paced speech. And then I also try to document their facial expressions. Like, you can see this poor gentleman on the side. Like, he appears sad, right? He doesn't look happy. So can you guys think of a time where you would need to document happy? Patient appears happy.
We told them they're pregnant.
Yeah, that's true. Like, if you're gonna give them news that they're pregnant, you need to know, are they happy about this news, or are they sad about this news? I will tell you the one time I use happy is when I have a parent coming in with a child that they think is dying, or they think is really sick. And this kid is bouncing off the walls, running, pulling off my stuff, getting into my table, and acting like a normal kid. I will say this is a happy child, because you're going through this HPI with this mother who says, he's not eating, he's not drinking, he's sleeping all the time, he doesn't want to play with his brothers like he used to, I can't get him to do this, I can't get him to do that. And you're like, you state your general appearance, and you tell the truth. If this kid looks happy and he's smiling and he's interactive, there's a disconnect here. And so I say, do you feel like your kid is doing that right now? And sometimes they'll say, no, he was doing this all weekend and now he's fine. Or sometimes they're like, yeah, this is him. So you can tell, kind of get an idea. That's one time I use happy. It's usually when a parent or a loved one is complaining, or you have a husband and a wife come in, and the husband's like, she's just not acting like herself. Like, she's sad all the time, she can't stop crying, and she's sitting there and she's happy, and she's like, I just don't like you anymore. I'm fine. I have a really good time with my friends. I just don't like him right now. So it kind of helps you paint a picture, right? Okay, signs of distress. Let's say you have two patients. You have a patient in room 1, you have a patient in room 2. And both of their chief complaints are shortness of breath. Okay? You walk into room number 1, and I'm reading your documentation later today. You go see both these patients, and you come back and you give me 2 documentations. And in room 1, it says, patient is a 34-year-old, well-developed, well-nourished male in no acute distress, AAO times 3, awake, alert, and awaited times 3, talking at a regular pace, is well kept, with occasional coughing throughout exam. And then I read your note on page 2. Patient is a 64-year-old African-American female, using accessory muscles to breathe. She is very short of breath, is unable to carry on a conversation, appears unkept, appears acutely ill. You see how you're setting up the note. You're painting me a picture of what these patients look like, so I am in the right state of mind when I read this note. You see how important the general appearance is. Okay, good. If this is a mental health patient or a mentally altered patient, you want to document the relationship to people in the room or themes. Or do they have an appropriate relationship with you, the provider, and other people in the room? Or did they not understand when you said get up on the bed? They just sat in the chair, and then you said, look, come on, let's move on to the bed so we do your physical exam. And I don't see a bed in the room. I don't know what that is. That's a cabinet. You see what I'm saying? That's an altered mental status, so you would document that. So some other things. I usually don't document these unless they're abnormal. But if they're abnormal, I really want to see them on the notes. So if they have a slouching posture, if their motor activity, if they're moving a lot, they just have this exaggerated activity, or you're asking them to do musculoskeletal exam and lift your arm. And the other one. That's a different kind of patient. I try to document their gait. Sometimes when I walk into the room, they're already sitting down. But if I'm concerned about their gait anyway, if they're there for a musculoskeletal complaint or they're elderly and I want to document their normal posture, I'll ask them to get up and walk down the hallway and come back. And I just document how their overall gait is. Are they limping? Are they dragging a foot? And I always, always, always document any devices. If you walk into the room and there's a patient sitting in a wheelchair, you better have in your note, patient sitting in a wheelchair. I better know that before I walk in the room. So I had a student come in, she went in to see a patient, came out, she presented this perfect 25-year-old person with a UTI. Just straight textbook. She had had dysuria, she had had nocturia, she's been going more frequently, painful urination. It happened, for 24 hours, starting to not feel well, needs antibiotics, gonna start on macrobid, blah, blah, blah. It looked perfect on paper. I was like, great job. I go in the room, this girl's sitting in a wheelchair, she's a paraplegic. We've got a whole other story here, guys. Why? If she's got a UTI, then she was self-capping, which wasn't in the note. You have to really put the picture together. Always. Use of cane. Sometimes elderly people will come in a cane, especially after a surgery or an acute injury, and they only use it for a couple of weeks and then it's gone. Sometimes this is a progression that I need documented for when family comes into town on Thanksgiving and Christmas. Last August, she was walking with a cane, and then January, she's now in a walker, and now she's in a wheelchair, right? We're seeing a progression, so I always document what devices they come in with. So here's an example of a physical exam. She is a well-nourished, well-developed 43-year-old female in no acute distress. She is alert and oriented ×3. Speech is appropriate. She appears well-groomed and cheerful. That can be any of you guys, right? Like you can walk in, you're not 43 and you're female, but you can probably see this in your medical chart. Here's another one. Patient is 68-year-old Caucasian male from a rural area, brought into the clinic by family members. He is cachectic with loosely fitting clothing. His face shows sadness and fear. His speech is difficult to understand, and a fecal odor is evident in the room. He is pale. There's a hole present in his left shoe where his large toe protrudes. Paints a picture, right? You can see this guy. You know exactly, you can paint a picture of what this guy looks like, what you're walking into the room to see. You know his family's there, right? So someone is concerned about him. You already know, if you're a consulting doctor or you have a resident give you this note and you just knew this line, you can already come up with a differential diagnosis. There's some things on your radar. Dementia, you know, you have this is just as important as a heart exam or a lung exam. Do not discredit it. Okay, your turn. Okay. Yeah.
If the patient wasn't oriented to like a place, how would you document it?
Not oriented to place.
Okay, so
Mhm.
we would just say,
I don't always type back in the question. I can just say not oriented to place or time, but oriented to person. Or patient not oriented to person, place, or time. It's
What
really
did you say CM meant?
Caucasian male. Okay, so it's your turn. Someone describe this female to me. Okay, so who said happy? So good more. This is a, okay, so this is, what age do you think she is?
This is a 25-year-old Hispanic female that presents with a healthy appearance. She appears happy, well-nourished, well-developed, with no acute complaints. She's dressed appropriately for the time and season, and appears well put together.
Perfect. Perfect. Okay, somebody else. All right, Blair, now you can do this one.
Yeah, she took over.
She did.
That was my answer.
She took it away from you. Let's try this one.
All right. That was really good, Taylor. She's about a 20-year-old. She looks sad. I would say acutely ill. She looks nourished and well dressed.
Did anybody else say anything about her right now? Yeah, she's well nourished.
She appears in apparent pain.
Yeah, she appears to be in pain. In some pain. I would document that. If I walked in the room and she's sitting there in the chair, looking like this, I would document appears acutely in pain.
Would you do posture like that? She's
Yeah, slumping down, holding her abdomen, all that's perfectly, that's where I would put that, paint that picture at in general appearance. Okay. How would you document this? Anyone?
Would you document like the appearance of the child?
Well, yeah, does anyone know what the disorder is? Down syndrome, I would say appearance similar to that of Down syndrome. Appearance similar to that of cerebral palsy. Appearance similar to severe cerebral palsy, or mild cerebral palsy, or mild retardation, or moderate or severe.
When you would say happy, and I would say
Say happy.
8×3.
Yeah.
You'd want to document on him if he was engaging with the people in the room and able to answer questions on his own.
Absolutely, the speech would be important for this person, right? Absolutely. I mean, he's standing in front of a microphone, so I'm assuming that
Yeah.
his speech is gonna be understandable.
I have a question about the speech. Would you sometimes document the speech under a neuro exam instead of the general? I mean, wouldn't slurred speech sometimes be related to that?
Yes. Absolutely. I like just painting a picture of what we're looking at, and then when I do specific tests, I may then, if I'm doing a specific language test in the neuro exam, I would document even further. Like slurred, speech is slurred but understandable, or speech is slurred, unable to complete a Cognizant test or a mini mental exam due to inability to understand patient.
So on the test, are you gonna give us scenarios? And we have to like figure out what's kind of missing?
No, that'd be too easy. That'd be too easy. I don't know. These questions are gonna be like, mine and Nikki's lectures going together. So you will get 7 to 12 questions for this whole break. So there may be anywhere from 3 to 6 test questions over this part of the lecture. So it's probably gonna be like, if you're alert oriented times 3, which of the following are you not documenting? Does that make sense? So that's gonna be the type of test question here. You're not gonna have a picture of a person and say which one of these is not true for this patient.
Is the age necessary for general appearance?
No, not always.
Okay.
I have used age through here because I want you guys to see the picture. A lot of times on your medical chart, the age is gonna be there in electronic records, so you don't have to restate it. It's at the top of the page. You
Right.
just have to scan up.
After we got done talking about biases, this is something that I saw with some physicians. Some physicians wanted us to document what their race was or their ethnicity, and others did not. Do you?
I always document
okay.
race and ethnicity.
Okay.
Always, in general. I don't know why you wouldn't, because different races will predispose you to different diseases.
That's what, if it was like a pertinent condition, but if they just came in with like shortness of breath, then they would say like, you don't need to put in what their race is, because then they were saying, if I put in, say, a certain race, and then it was like a malpractice suit or something, I don't know.
Yeah, if you got it wrong.
Right,
Yeah.
yeah.
Yeah, so if I don't know, like, if I'm confused, then I'll just put 28-year-old male.
Okay.
I can't tell. But Hispanic, Native American, African American, and white, I can usually pick out a crowd. Asian, I can sometimes I'll put 25-year-old Asian female. So you don't have to be super specific, but if you're doing your good social exam, you should already know.
Yeah.
So sometimes I would put, 45-year-old Pakistani male, because I know he's from Pakistan. I know that's where he was born. I already did that in my social. I know his whole family's there. I know he's here just studying right now. Okay, last one. Come on, someone, raise their hand. Don't make me pick, I'll pick. Okay, you, Bradley.
He's a
Confused, she's not looking at me.
Sorry. Bradley, apologize.
25-year-old male that is undersized.
Yeah.
He is dressed inappropriately for being at the doctor's office.
Yes.
He appears stern, but not unhappy. I don't know what else to say.
Does anyone watch Game of Thrones?
Yeah.
Okay. He thought he was fixing to die, so he was very fearful, but you may not know that unless you were a big GOT watcher. Yes, she did a great job. That's exactly how I would describe him. And I'm so glad you mentioned dress, because it would be out of ordinary for this to come into the office, right? Sometimes I would say that this is not unlikely to show up in the ER. Okay, so these are some disorders that will affect general appearance. This is a very short list. You're going to learn a lot more that whenever we start getting into these specific systems that we're going through. This is just a short list. Probably the most common is going to be obesity, especially in Oklahoma. That's what you're going to see. Obesity is a number. It's rankable. In most medical charts, you will know their BMI before you see them. It's part of their vital signs. You'll have their weight, their BMI, and so you will already know before walking in the room how to diagnose these people. Anything over 30 is obesity. And then I think, what is morbid obesity? Is it 38 or 36?
I don't remember what morbid obesity is.
I don't either.
I think it's 36.
I think it's 36 as well. Upper body obesity and lower body obesity will predispose you to different types of diseases, so I document that. And then it also will let you know if they have any impairment with glucose. People that are obese or morbidly obese are gonna have greater risk of having resistance, hypertension, high cholesterol, and you will learn about metabolic syndrome. So you can see this is a central obesity. He has an elevated waist circumference greater than 40 inches. Women greater than 35 inches is considered elevated waist circumference, central obesity. Lower body obesity, pear-shaped individuals, they're at a lower risk of diabetes than central body obesity. Anorexia, this is a mental health disorder. They have a fear of becoming overweight despite already having a very normal weight. Anytime their body weight drops below 15% of the expected value, you can diagnose them with anorexia along with mental health issues showing up. And also they will not have a menstrual cycle, they'll become amenorrheic. They don't have enough fat cells to produce estrogen to allow you to have a period. So they'll have amenorrhea as well. So you would document this person as cachectic. You can see there's muscle wasting here, and you can say their appearance is similar to that of someone with anorexia. Okay. Acromegaly, this is due to a pituitary tumor, and you get too much growth hormone. So these people are very large, they're overdeveloped, they're tall, very large bone, large structure, and they have really large growth of their hands and their feet, their jawline here. It causes really coarse facial features, and they usually have a deeper voice. Women will also have amenorrhea, but not because there's not enough fat cells, because this pituitary tumor has affected their FHLSH hormone levels, which you'll learn about, and they are unable to have periods. So you can tell this doesn't look like a normal hand, right? This is an acromegaly hand. Wide jawline here. Have you seen Andre the Giant? He was like a wrestler. That's acromegaly. You can see he looks different. He doesn't look like normal people, right? Kevin Durant's a big guy, but he's proportionate, right? His hands are long and skinny. They're comparable to his arms and his legs and his torso. Acromegaly, they don't appear proportionate. They're just larger than average. Cushing syndrome, you're going to learn a lot about this in endocrine. It can be caused by drugs. We give them drugs that cause Cushing syndrome, or they can have excessive cortisol production due to a malfunction of their adrenal glands. I have some more pictures to show you. So she's an example of Cushing syndrome. She has a very round, large face that's usually paler. They call this moon face, and they will sometimes have red cheeks on their moon face. They also have very central obesity with thinning of the upper extremities and lower extremities. So here's a picture of a Cushing syndrome, and this is literally what they look like. I can pinpoint Cushing syndrome at Walmart all the time. So moon face, red cheeks, it's common. It's more common. It's common, especially. I will tell you one thing that causes this. A lot of people have severe arthritis or rheumatoid arthritis or autoimmune diseases. They have to put them on really high doses of steroids, and steroids can. Long-term usage of really high-dose steroids causes Cushing syndrome. So you see this a lot more, we call it iatrogenic, means I caused it. They didn't have it, but I caused it. But you cause it in order to fix something else, or due to drugs or something else. They get the buffalo hump. Yes, not everyone who has a buffalo hump or a fat pad has Cushing syndrome. Some people have lipomas back there. Some people, that's just where they deposit their fat. And if they lose weight, the buffalo hump goes away. With Cushing syndrome, if they lose weight, the buffalo hump doesn't go away. Okay? They have really thin skin. They're easily bruisable, elevated blood pressure, and their stretch marks, their striae on their skin, upper thighs and abdomen is almost a purple color. It says red here, but it's really purple. It'll be so red it appears purple, so not a normal type of stretch mark. Pendulous abdomen, and then they have really poor wound healing. And a lot of times they'll get osteoporosis, and they just kind of look like Cushing syndrome. They just look like this. They're just heavy, and thin little arms and legs, and a rough little hump. Yeah, good.
Oh, I was just gonna ask if you stop whatever medication they're taking, then it causes this or go away? Or
Sometimes, it depends on how high the dose is for how long. Congenital birth defects. So you want to document anything that just doesn't look right. And there is a medical term, is FLK, means funny looking kid. I know, right? If you don't have a word, if you don't know what's wrong, but you know this kid doesn't look normal, you document FLK until you find out what's wrong with it. What is not a true term is FLA, funny looking adult, which I use all the time socially amongst my PA friends. Like if you see someone like, oh, she's an FLA. But do not document FLA in your chart. That is not a true medical documentation. But FLK is a true medical documentation. I know it sounds funny, but a lot of times, especially in newborns, when they just don't look normal, but you don't know, you haven't gone to the diagnosis to see what's wrong with them, you diagnose FLK. I would also recommend that you look at both parents before you document FLK, because sometimes they look at FLK and then you see dad and you're like, okay.
Never mind, no more parents.
Just like you should.
Sorry.
So, be careful. Does anybody know what this is? Left palate. So if you walked into a room, you would document this, correct? You would not, this is not a normal, well-developed newborn. So when you look inside, there's also just one picture of a cleft palate. Palate's not thoroughly formed. And can you see his nasal fold? That's not normal. So he would not look, even if his mouth was closed and he was looking right at you, he would not appear well-developed, well-nourished. There would just be something off, and you would document FLK. And then you look inside, you see the cleft palate, it all makes sense now. Okay? Precocious puberty, that would also be documented under general appearance. They develop secondary sexual characteristics prior to the age they should. For boys it's 9, for girls it's 8. They have increased growth size of their genitalia. For girls it's breast and pubic hair, vaginal hair, underarm hair. For boys, it's penis and testes. And this is abnormal to the age. After 9, after 8, it can be early, but it's considered normal. Okay? Before 9 for boys, before 8 for girls, it's abnormal, and you document precocious puberty. For the most part, we don't know what causes this. Sometimes it's genetic. Congenital adrenal hyperplasia, they're born with very large adrenal glands, and they just develop their secondary characteristics sooner. Sometimes they can have a tumor, and exogenous exposure to estrogen or testosterone can also cause this in kids. So this is a young boy under the age of 9. If you saw this while doing a well-child check, you would document precocious puberty. If this was a 6-year-old boy or a 7-year-old boy. Okay? So this is a little girl who has abnormal breast development under the age of 8. You would document that. Okay, any questions? Yeah, Billy?
Most of the things we've talked about up here is subjective, some more subjective than others.
Okay.
Are there any rules as to what can be documented as part of the general appearance? And so, for example, some of the information you may have gotten from talking to the patient, others may just be visual.
Give me an example.
Okay, so for example, I walk into the room and I'm not sure of the race, and that comes up in conversation, and I put it in my my general exam. Is that still general appearance, because I got the information. And then,
Well, okay, so you did get the exact information, but you had an idea, right? You either know they appear Caucasian, or they appear African American, or they appear Hispanic. Once you become a provider, what you see, what you diagnose, what your subjective thoughts are, becomes objective. You become the objective person. You're taught and trained how to look at things and diagnose them. So when you see something, this is your objective opinion. So I will tell you, I do not usually document race in my physical exam. I usually document race at the top of my HPI, like a 25-year-old Hispanic female, or Caucasian male, African American female. So that's where I document it. I usually don't document it in general. I did here because I really wanted to paint you guys a picture. Same with age. I don't document age or race in the physical exam. That's in my HPI, or it's part of their notes somewhere else. I don't reproduce it. I'm painting a picture of what I'm looking at in the room.
okay. So height, weight is obvious as you're looking. Something like BMI, you may have calculated.
Right.
So that's still general appearance.
Yeah, that's objective. That is scientific data. There's a number matching that. Just like temperature. Temperature is an objective. If I stick a thermometer in Alex's mouth and it says 98.6, that's objective data. If I look at you and your BMI is 34, you're an obese male. That's objective data, right? So what you see and how you diagnose does become objective information. I mean, just think, if I'm listening to the lungs and I hear wheezing, that's objective data. I heard it, right? So it's what you see and do becomes the objective part.
Question of the boy, you did mention that when he had cleft palate, that he was not well developed and not well nourished. I would
I
say.
didn't say well nourished. I said he would not be well developed. There's parts of his body that have not thoroughly developed.
What do you characterize as well nourished?
Well nourished is appropriate. Is you're within your appropriate BMI. You're well nourished. I don't do that a lot, unfortunately. Yeah, a lot of times with kids, I mean, EMRs now, with meaningful use, which you're gonna learn more than you want to about, whenever a nurse puts in a patient with their height and weight, it automatically pops up this general, screening, like, this patient, is overweight, give, nutritional advice, or this patient is underweight, you need to, discuss, feeding. So with EMR, it tells you almost immediately where they lie. And that's only gonna get more and more with this new move towards preventative care rather than acute care, the prevention model. So you will have that access.
At what age are you required to contact CPS for an underweight child? At what age is that? If they're like extremely underweight and it's a child?
Okay, you mean Child Protective Services?
Yes.
I see a lot of underweight children. My son was underweight, and it's not because of neglect. Sometimes it's because of malabsorption or a medical condition that you need to diagnose and figure out. Sometimes it's just the parents need education on feeding. My son, he had what's called toddler's diarrhea when he turned 1. Everything he ate just came right through him. So we could not feed him enough calories to keep up his nutritional status. We started supplementing with this super high calorie formula, and within 3 to 6 months, he was back on his growth chart scale. So, anytime you think there's neglect, you call CPS, Child Protective Services. And sometimes the patient can't afford food, right? You get to the bottom and you say, why, this kid is underweight, and you're like, what is he eating? And she's like, I only have enough money to feed him 1 meal a day. So we need to get you resources, and luckily we have those in Oklahoma. So,
If there's a child who's severely obese, and you've looked into it and it's just nutrition, could that be considered neglect?
Not yet. I think, no, it's not. I don't know when we'll ever get that way. There's such a stigmatism with obesity and overweight that, and a lot of, I actually read a study recently that they looked at 100 children who were obese, past overweight, obese, and they asked their parents, do you think your child has a weight problem? 70% said no.
Because the parents are the same way.
Or they don't see it in your kid. I mean, you think your kid's perfect. You look at your kid and you think, oh, they need to be chubby. They need that. You know, it helps them run, it helps them play. They're healthy. They're healthy, you know, they're sturdy. So it's all about education. And it's not considered neglect at this point. Good question.
Isn't gonna help them run.
That's hilarious.
Any other questions? Okay, do you want a break, or you guys want to roll on with the next?
You guys want a little bit of break?
No, well,
It'll take a little bit to pull up the next slide.
Yeah,